This is about testicular tumors, particularly meant for postgraduates. They need to know about the basics as well as the avenues which are available now and how well it can be managed and what is the prognosis and things to be done in advances in testicular tumor management. Next. This is our department, Madras Medical College, in 1983, where you had Professor Sarachandra, Dr. M.G. Muthukumar Sami, Dr. Arumugam, Dr. Umapati, and all the senior people are around. You can see Dr. Ratnasamy standing next to me. See, like testicular breast malignancies are diagnosed by breast self-examination. Testis also is to be examined periodically for a testicular self-examination, where you find lesions like epididymal swellings, testicular swellings, heaviness, cord structures, thickness, all that can be taught to a student. In fact, Hebrews, they used to testify in a common etiology. So the testis word is from a word testify, and for holding the genitals while swearing an oath. It is not all that overwhelmingly present. It is usually a rare presentation. And historical testicular tumors are 84 cases in 4 decades. A senior person like Brandy had done. Testicular ulcers only accounts for about 1% of the cancer in men. Sir, Gordon-Taylor's classification is what the questions which are normally asked in the exam, but it is no longer now followed because we have the WHO thing has come. The Gordon-Taylor's classification is a hurricane variety, ordinary variety, abdominal secondary variety, epididymo-archaic variety, and endocrine variety with gynecomastia. The hurricane variety is called because it's a rapid progression. The day one he finds swelling in his scrotum, third day he coughs out and he has got a supraclavicular node on the next 15 days and he dies of pulmonary metastasis. So there is called as hurricane variety, and it is not very rare to have a malignant tumor of the testicles, but you can have malignant tumors misdiagnosed. It's a quiz for our postgraduates around what exactly is this. It is a lead protection of a testis, which a person is having a radiation to be given for one testis, the other side is protected. You have what is called as lead protection. This thing will be used in St. Bartholomew Hospital. This is the military surgeon, Sir Gordon Taylor, who said curable. From his days, in about 50 to 60 years, the testicular tumor, the tumor model, post cisplatinum era, you have got nearly curable. How do they clinically classify? I told you one aspect of hurricane variety of testicular tumor. Second is the plainness swelling, thickening of cord, all this for about 3 to 4 months, and the history of trauma on a cycle, metastasis in the supraclavicular node, or a gynecomastia, or an epididymo-archaic variety. These are all the way they present. Usually it start thickening sensation on compression of the testis. We call it as a testicular sensation. Absent in a particular side is suspicious of malignancy. But it is a sign not to be done in the examination or in the wards, because it can pump up the lymphatics and then send all these tumor cells up the lymphatics. Painless testicular swelling to the supraclavicular nodes and para-aortic nodes are not uncommon. The land of filariasis and tuberculosis, you are very familiar with these kind of inflammatory diseases like filariasis and tuberculosis, epididymo-archaic. And one more addition to that, tuberculosis and filariasis, is lymphoma. Lymphomas are usually bilateral in the presence of 70 years age. diffuse B-cell lymphomas are common, and most of them normally occur bilaterally, are associated with multiple lymph nodes all over the body. This is also a question in the exam. The epididymal cyst is called as a Chinese lantern, and these sites are called as tessellated sites. Tessellated sites. And the testis can be injured by a cricket ball injury, producing a hematoma. What? Hematoma, getting infected, biocele, and all that needs an orchiectomy. Then, there is no role of biopsy initially. Management of testicular pathology is tumor seedlings, altering lymphatics. So, biopsy is not done, but there is a provision for doing an FNAC in intratesticular germ cell tumors. And Chavasu's maneuver is a procedure where the cord structures are exposed and the testis is lifted up, and with a clamp, the testis is nibbled like a book to see what is happening. And when you do this, you will find inside a small area of malignant foci, which can be done by a good pathologist. So the risk factors for early orchiectomy is mild descent. Suppose somebody is having a mild descent, it is earlier, it is done, less than a year. Family history, gene-related chromosomes, gonadal dysgenesis, male factor infertility, HIV infections, carcinoma in situ of the testicles. These are all coming up, which you may get more number of cases subsequently. So you have normal pathological features. Actually, age group between 20 to 40 years is a usual testicular germ cell tumor. Younger age group, you have got mature cystic teratomas. Elder age group, spermatocytic seminoma, which is an anaplastic one, Aryan, and bilateral non-Hodgkin's lymphomas. You have down and left, you have the seminiferous tubules. On the right side, you have got the Leydig cells and Sertoli cells. Leydig cell is the interstitium secreting testosterone, and Sertoli cells nourishes the testicular spermatic fluid. Mediastinal germ cell tumors is about 3%, and this is which accounts for 95% rest of the things. So the testicular tumors are germ cell in origin, majority, both germ cell tumor and stromal tumors. Embryonal carcinomas, these are all included in non-seminomatous germ cell tumors. Embryonal carcinoma, lymphoma, choriocarcinoma, teratoma, yolk cell tumors, and stromal tumors are Leydig cell tumors, which are all more commonly in the primary testicular lymphoma. Imaging was in its infancy. Last 30, 40 years back, imaging was at its infancy. When you have a lumbar aortogram and a retroperitoneal air insufflation or a lymphadenography, where all is available, which is technically very, very not accurate. So testicular tumor, radical inguinal lympectomy, the incision has to be inguinal. Never ever put a total incision and then do a orchiectomy, which is banned. It is a crime. The most common type of cryptorchid testis is seminomas. When you explore, you immediately do a exploration and do an orchiopexy if it is lengthy, and if it is not lengthy, it is excised and sent for biopsy. Laparoscopic detection of intra-abdominal testis is done by a pediatric age group with testes at the internal ring inside. And cryptorchidism and testicular germ cell tumors, a lot of studies have been done. It is 5 times more prone to develop a testicular germ cell tumor. With the advent of high resolution sonography, you have various methodologies to detect testicular tumors. And testicular cancer is a reflection of 50 years of discovery of MRIs and CTs. We find it has come to a routine management that you need to use this ultrasonogram, testicular CRI, CT, all that has to be done. So lung symptoms you have to ask. Inguinal nodes, if it is an hydrocele already done, you need to look for inguinal nodes. Surgery with lymphatic breach, that is previous total surgery, or bilateral if it is present, non-Hodgkin's lymphoma, look for other nodes. Left-sided testicular tumors typically spread to the left para-aortic nodes and just below the left renal vein. Left is slightly longish. Right-sided tumors usually spread to the retrocaval, paracaval, precaval, and disseminate to the right side. Crossover occurs very commonly from right to left than from left to right. You are able to follow. You have a testis on the left side. It takes its own time to cross over to the other side. But right-sided testicular tumors crosses over the midline faster because it's a short reach to the aorta. This is what I was telling you about Chavasov's manual, where the testis is opened like a book. Maurice Chavasu, a French surgeon, a pioneer of the study of therapeutic testicular neoplasm. Those days it was routinely asked in the exam. Management of testicular tumor in introduction. Stage 1 and 2B, the cure rates are 100%. You won't believe. You tell a senior surgeon, testicular tumors with hurricane variety, patient is having 100% cure rate. They won't believe. That is the introduction of platinum-based chemotherapeutics made testicular tumors are one of the strong models of cancer cure. So there is a gross reduction. This entire thing is made possible by a physician by name Donohoe and Lauren Yeinhorn, who is a surgeon. They have done the maximum number paper in the Indiana University School of Medicine with bleomycin, etoposide, and platinums. Highest success rate for any cancer again. And the monumental work by Mustafi, it's very important that the current classification was arrived at the WHO consensus at the FK Mustafi. They read dark and pale dermatogonias. There is an aberration in carcinoma in the brown variety, and the classical seminoma occurs from tumorigenesis, during tumorigenesis. Totipotent primordial cells, abnormal differentiation, non-seminal matters. So embryonal carcinomas are intraembryonic and extraembryonic. Intraembryonic is a teratoma. Extraembryonic is yolk sac tumors and choriocarcinoma. Obviously, yolk sac will have AFB positive. Choriocarcinoma will have gynecomastia. Teratomas will have HCGs, and seminomas have got only HCG. That's pure seminomas. Rule of 95. Germ cell tumor. Extra gonadal germ cell tumors. Then gonadal germ cell tumors. Germ cell tumors with the testis. Prognosis in early stage 95%. And this also asks the cut section of testicular tumors. Usually it is variegated appearance. Variegated appearance is found in testicular seminoma, teratomas. And testicular seminoma is a uniform tissue. This is the basic plan. All are operated, the biopsy is done, the tumor marker is taken, and ultrasound is done, and then the patient is taken up for surgery within 5 days. Within 5 days is said because the half-life of AFB is 7 days, 5 to 7 days. And after that, if the biopsy is there and the abdominal scanning shows no nodes, there is nothing is required. It can be in a protocol of surveillance, that is all that is required. Tumor markers, two main types, oncofetal and cellular enzymes. Oncofetals are the classical age-old AFB and HCG. Cellular enzymes are LDH and FLAP. Alpha fetoprotein is trophoblastic cells, while HCG is from syncytial trophoblasts. Syncytial trophoblasts is a variety of omental tumors. Cyclin or the cell cycle markers are also useful for diagnosis. The concept of managing for seminomas is by radiotherapy. For the concept for tumors, the germ cell tumor is retroperitoneal node dissection because it melts with our radiation. Our seminomas melt with radiation. It was initially planned by Plant Sutton and Robson's lymphatic drainage mechanisms, and laparoscopic RPLND is being done. And the entire retroperitoneum is mapped. What is called as a template is taken by various investigations done, and the place is completely taken off by excising all the lymphatics. So the volume it has to be done, and functional outcomes are better in a high volume center where they do a minimal access surgery with testicular RPLNT, or otherwise called as retroperitoneal node dissection. It can be post chemotherapy. It can be post complete response to surveillance patients. It can be neoadjuvant, or it can be post operative, or it can be after salvage. IS marked in NSGCT, that is the non-seminomatous germ cell tumor, is defined as persistently elevated serum markers without image findings. If you don't have an image finding and you have an elevated this thing as a first stage, primary RPLND as an emerging territory treatment for early stage carcinomas. Because once the diagnosis is there and there is nothing in the abdomen, you can either give a prophylactic chemotherapy, prophylactic radiotherapy, prophylactic surgery. But all the three are much inferior to surveillance program protocol, which is much better from the quality of life achieved. See the good prognosis, interim prognosis, and poor prognosis of germ cell tumors, 5 years survival is about 90%. The prognostic factor based classification is only found in testis. You have no other this thing like sarcomas. I told you the other day, you have sarcomas, you have the G incorporated. Tumor node metastasis, TNM plus grade there. Here it is the presence of prognostication by enzymes, tumor markers. The investigations are CT scans and chest X-rays, all that is required. The TNM staging, M1A is a metastasized to the regional lymph nodes and to the lung. Distant lymph nodes and the lung, it is M1A. If it is 1B, tumor is metastasized to other organs such as liver and brain. And what you should also know is there is no stage 4 in testicular tumor. That is a very important thing which is not. There is no stage 4 which has been documented, and there is no stage 4 as per the records. So it is not included in stage 4. This is about AFB levels which are not elevated in seminoma, very important. If increase, they are treated as NGST. If you have a seminoma plus teratoma, you just be treated as non-seminomatous germ cell tumors, teratomatous tissue. If you have papillary carcinoma and follicular carcinoma mixed variant, it is treated as papillary in testis, thyroid. If increased, they are treated as half-life time is 7 days and HCG is 3 days. If facilities are available, it is taken before surgery, and if it is not, within 3 days. Similarly, you have very many marker studies like LDH, which is included in the TNM staging, which S1, S2, S3 as marker studies. Memorial cancer surgery staging system. Management of testicular tumors with secondary surgical violation. Local recurrence, local nodal metastasis, it increases. Total violation alone without tumor contamination does not impart a worse prognosis in patients with testicular tumor. This is one of the fundamental studies which said total violation can be think the spillage is more dangerous. So you put a scrotal incision, you give a dose of radiotherapy at that place for a seminoma that takes care of the violation. So violation is acceptable, not acceptable, but it is less dangerous than contamination. PET scan is done only for a residual seminoma. Management of testicular tumor. Now each stage, each type has got a treatment protocol. So stage 1, seminoma, it is only surveillance for 5 years. For 3 months review and ultrasound is used, tumor markers are used for review in the post-operative period. So surveillance, they live on surveillance. Seminoma stage surveillance, single agent carboplatin and very bulky tumors are present. If it is stage 1, there is no question of that, so it is not done. Radiotherapy, RT dog leg field. Radiotherapy by a dog leg field that is including the iliacs. Prognostic factors of low volume stages. Adjuvant therapy is given. The bulky tumors, 4 centimeter and more, it is given, chemotherapy is given. Non-seminoma stage, vascular invasion present, the chemotherapy is given. Management of testicular treatment protocol for stage 2, seminoma, stage 2 radiotherapy with bulky BEP, we give 3C chemotherapy. So, first priority is radiotherapy, second priority is for bulky tumors, the chemotherapy. In stage 3 seminomas, sites of metastasis and tumor markers are assessed. Good prognostic index. You have 3 cycles of BEP. The intermediate or poor risk based, it is 4 cycles of thing is followed up. For management of testicular tumors, stage 1, non-seminomatous tumors, surveillance, BEP, RPLND. This is what is normally given for the first seminoma. But there is no need for adjuvant chemotherapy for N0 pathologically. Adjuvant chemotherapy is based on nodal involvement for positive bulky tumors. And stage 1B and 1S for teratoma, persistent tumor marker elevation. Stage 1B local spread, 4 cycles of etoposide is given. Elevated tumor markers with 3C, it is treated with BEP regime. Low volume nodes, RPLND is done for NGSC. So we are planning for low volume fixed nodes present, less than 6 nodes present. The treatment is RPLND, intraperitoneal lymph node dissection. Stage 2A, serum tumor normal. For non-seminomatous germ cell tumors, chemotherapy is a must if it is bulky, adjuvant chemotherapy. No stage 4. Stage 1 is localized, stage 2 is regional, stage 3 is disseminated. Similarly, you have got risk, good risk, intermediate risk for seminomas. There is no poor risk classification in seminoma. So the testicular testing, staging and management varies. There is no stage 4. There is no poor risk involvement. Non-seminomatous risk status, good risk of non-seminomatous, intermediate risk of non-seminomatous, poor risk of non-seminomatous is usually depending upon the pulmonary and visceral metastasis and tumor markers. Seminomas is radiosensitive. Dog-leg yielded excellent results. Management of testicular tumors way. 95% of germ cells are gonadal, 5% are extragonadal. Germ cells are first seen outside the embryo in yolk sac. Extragonadal tumors can also occur in females. That's why people gonadal germ cell tumors present in the mediastinum. It's present in the anterior mediastinum. A very popular person was having a germ cell tumor was the mediastinal germ cell tumor, which is not that virulent. Pineal gland is also found to have germ cell tumors. Sperm banking you should think of due to chemotherapy, due to radiotherapy, or due to RPLND, or the same genetic mechanism that has produced a testicular tumor on the right side can produce it on the opposite side and suppress the sperm count. So it has to be done. So the testicular mass, a person comes, you do a right inguinal orchiectomy, you do it send it for HPE, the result comes as seminoma, stage 1, 2A, it is intradiaphragmatic nodal irradiation. Stage 2, it is stage 2 and stage 3 systemic chemotherapy. Non-seminomatous stage 2 and A is RPLND, the nodes are bulky, systemic chemotherapy. The nodes are completely remote, observation. So the breast front is seminoma and breast surveillance is done for 5 years by seminoma, which is not bulky, with no raised tumor markers. So you need to know about high inguinal orchidectomies. These are all asked in the exam. So the high inguinal orchidectomy is the thing where you don't put an incision in the scrotum. RPLND types, post-chemotherapy, pre-chemotherapy, post-salvage, all that. Tumor markers. When pure seminoma is secreting other tumor markers.
She lead off.
Chemotherapy success has made various strides in the treatment of testicular tumor. You have robotic RPLNDs, you have minimal access RPLNDs, prognostic index, a lot of genetic testing about cryptorchidism. All that are available in the literature.
You want to see Chivasu? What is Chivasu?
Somebody wants to show us.
Not Shivas. Chivasu.
Yeah.
Ultrasound.
You want to see that?
Is it done testicular making? No, I listen. It also must be there. That Patta sir will put every day one. I'll send it today. I didn't see. I didn't pay attention.
Come back to discussion, open discussion in a minute time. Seminomas from the right testicle has spread to the parietic nodes. Testicular microlithiasis in ultrasound is another growing field that to assess the need for FNACL testing.
Done. Half an hour took seminoma. What nonsense.
Thank you. Then. Now we'll open for discussion.
Testicular tumor is important. Anyways, I'll keep shit in there. Too much. No one will discuss. Yes.
Shriti, you are Srishti Kanodia. You are talking with the mic on and I'm getting feedback here. You can come again. You can talk. participate and tell your doubts. Questions, we can ask the questions. Dr. Bharat? Wait. Nobody here? Charan, please.
Sir, if there is like non-seminoma testicular tumor and it is like on inguinal orchiectomy is the first choice or RPLND should be done first?
Pardon?
In the non-seminoma like non-seminoma tumor, so should we go with RPLND or inguinal orchiectomy plus RPLND?
See, the first day one diagnosis, you plan for a inguinal inguinal orchiectomy.
Okay, sir.
And never do a RPLND without the biopsy.
Okay, sir.
And RPLND is done if there are factors to be done in the findings. You do it. That is only a second place to surveillance mode where major surgery is avoided.
Okay, sir. So there is like that if like on the CT scan there is lymph node are enlarged, and so then also we have to go only in inguinal orchiectomy and then RPLND after the histopathology reports.
The protocol of surveillance is also aided by you have chemotherapy, one dose of chemotherapy, or you can radiotherapy, which can be done instead of an RPLND. So the choice of RPLND is the surgeon is going to examine and he decides.
And what was the number of lymph node like protocol, sir? Like you said, less than 6 lymph nodes positive and more than 6 lymph node positive. Then what is on the basis of that?
Four nodes is normally considered 4 nodes.
4 positive nodes?
Yeah.
Okay, sir. Is there any site specific lymph node size?
Yeah, site specific, you have to take the entire along the external iliac, common iliac and the vena cava on the left right side, and you have got the aortic lymphatics along, para-aortic, and you have on either side you have para-echelon nodes, and the echelon nodes need to be removed, and inguinal nodes up to the internal ring where you have a high orchiectomy. When you do, you put a proline stitch. You identify the proline stitch if you are doing an RPLND and remove it. So the inguinal and iliac side, you search for the inguinal proline by stitch and then remove it.
Okay, sir. Thank you, sir.
Sir, there is a question. Someone says, how exactly is Chevasov's procedure done?
Go to
Chevasov procedure.
That is, it is done for mainly for doubtful, non-palpable when ultrasound is not available. Now is a serious situation where everything you have available. So there is no need for Chevasov's maneuver at all. A good testicular high resolution thing is able to find out. So the use of Chevasov's maneuver is coming less in day in.
Okay, sir. Any questions? Any other questions from the audience?
1 minute, Dr.Patta.
Yeah, yes, sir.
See, it is something like the soft clamp has to be applied with your vascular clamp. You have got the vascular clamp to the internal ring, and then open the thing like a book. Previous one. Yeah, this is Chevasov. More is Chevasov. You have the retate testis posteriorly. You got the mediastinal testis posteriorly. and everything, you have got tunica vaginalis and albuginous are completely closed, opened like a book, and then a biopsy has been taken. So Morris Chavasus is the common thing in the early 30s, 40s, but subsequently during 60s it lost its charm when you have nice ultrasound machines. Sonogram overtook that.
Okay. Any other questions to Professor Sivakumar?
Hello, sir. Hello.
Yeah, Pradeep.
Yeah, Pradeep.
Sir, hello. So, what are the group of lymph nodes we remove in RPLND, sir?
See, you start the dissection from the internal ring, and then take the external iliac, and then the internal and the paracaval, intracaval, retrocaval, and iotocaval nodes, and then it is done up to the midline, and then it is stopped. Earlier we are going up to the crura of the diaphragm. That the crura of the diaphragm up to that is not now removed. It is retrocaval, iotocaval is done. It is called as a swiping method. You make an incision, take the entire thing in one mass, and it comes out so well. You can start from the aorta or from the external ring, internal ring, and then completely remove the lymphatics. So these are all the lymph nodes that are removed: para-aortic and paracaval, intercaval, all that. Any lymph node that's present between the aorta and the IVC, and at the bifurcation, you need to remove the tumor tissues or normal tissues. Yes.
So, what makes a germ cell to differentiate into semina or non-semina, sir? Both are from germ cell, but what makes the difference between the differentiations?
See, the tumorigenesis, there is a small flaw, and the flaw is because the spermatocytic spermatogonias and all this, when they don't differentiate well, they have the accumulation of brown spermatogonia or maldeveloped pale spermatogonias. And spermatogonias, they go in the wrong path and develop seminomas. And it's a germ cell tumor, and also a teratoma is a germ cell tumor. So germ cell tumor accounts to about 90%.
Sir, there's a question in the chat box. Dr. Biplav, he wants to know, how do you manage a refractory retroperitoneal node?
See, this I share an interesting case we operated. In fact, a person about 35 years was brought to the hospital with a massive multiple cystic lesions treated in a good hospital, and with multiple cysts in the para-aortic and subdiaphragmatic and in the chest. We evaluated it, and then the past history were not given to me at all. And the patients, for some more reason, because his wife is a staff nurse, he didn't want to tell about cancer testis. So an inguinal lymph node was present, and the scar was there. And we found out from them it is a teratoma which is present in the right testis, has gone to the subdiaphragmatic place and treated by a good chemotherapy, given radiotherapy, and the patient had a multiple cystic lesions. And it has been clearly said, when you have a complex cyst in the abdomen, you think of testicular tumors, and you don't try to remove it because it may be post-treatment cystic degeneration. It's a very, very well-known condition. Post-treatment, well-known cystic complications. Even if you excise it, it is only a space-occupying lesion. And I found that it to be a cystic lesion. So multiple cannulas are put, and patient became perfectly all right. He comes for follow-up. He says, I've been leaking by a tube by my side, and he loses fluid from the intracystic space, and we manage it with it because it is all densely adherent to the diaphragm and the pericardium.
Thank you, sir.
So cystic, and the biopsy report is cystic fibrosis, no evidence of malignancy.
Any more questions from the audience, please, before we close the session? Anyone?
Sir, any role of IHCs in diagnosis, sir?
Fairly, seminoma is easy to diagnose. It's a cut section of seminoma is very easy to see. But if there is a doubt, to differentiate between stromal tumors and genetic markers, they can do IHCs. But otherwise, IHCs is not very much necessary to differentiate between testis, particularly seminoma and germ cell tumors.
Okay, if there are no more comments or questions, sir, thank you so much for a wonderful session on testicular tumor, sir. And I'll close the session.
Next, we will have on diabetic foot syndrome.
Oh, wonderful, sir. Sure, sir. When do you want?
Because not many people speak on diabetic foot for undergraduates and postgraduates.
Yeah, nobody for that matter. So that will be wonderful, sir. When would you be free for this class so I can make a note?
Saturday, 6 o'clock. You have some meetings?
No, Saturday 6 o'clock. I'll fix it, sir.
Right.
Thank you, sir. Thank you.
Any other question from this audience?
There's one question, sir. I'll just.
Why right tumor goes to I think the left tumor goes to left.
Fantastic. That's a good question. Right tumors go to the midline where we have all the short IBC and short renal vein. But the left renal vein is longish. You have the testicular vessels come up to the aorta, then it's on the left side of the midline. It crosses to the thing, it takes time. So normally there is right is bilateral, left is less bilateral. So right, I would have faster, left crosses over.
Any further questions, please? Sir, thanks, sir.
Thank you.
Thank you so much for a wonderful evening session.